Welcome, everyone, to the Follow Brand Podcast. I am your host, Grant McGaw, and I get the chance to bring back two of my favorite guests. I cannot believe it. As we get close to the 200th show on Follow the Brand, I couldn't think of a better way to really get to this milestone without you. We've got Dr. Tania, we've got Damon House here, and we're going to have a real discussion. It's not just about technology. Last time we were here, we were talking about cybersecurity. We were talking about things that are going on in the emerging technology space with Damon House. Today, we're going to talk about some things that are very, very important for a lot of people, and especially underrepresented communities that we all represent. We're talking about awareness to action, advancing health equity and precision medicine today. And we're going to talk about how we can take action around some things that are very, very important. So we're talking health equity, precision medicine, and the urgent need for action. So I want to introduce you now. First, we'll go to Dr. Tania, and then right after she finishes up, let's go over to Damon House, get us introduced, and let's talk about this important subject.
Okay, well, I will not get on a soapbox so early. My name is Dr. Tania Marie Martin Mercado, Dr. Tania for short. I am the CEO of Frenetic. Frenetic is a biomedical research organization that is dedicated to bringing precision medicine to research in healthcare. The reason why this is important is the life cycle of how you get your over-the-counter medication has an entire back office cycle, starting with research and ending with patients. We as patients get those drugs after research has occurred. It's been released into the commercial space and then approved by your doctor, by the FDA, and then prescribed by your physician. So that's the life cycle of medication, of treatment, of care. It starts with research, ends with healthcare execution. And what we're going to address today is how Black, Brown, other underrepresented communities are not involved in that cycle and are being woefully left out on a consistent basis, meaning that treatments, medication, and so on and so forth is not tailored to us.
Interesting. All right, Damon, let's hear from you.
Not much left to be said, but hello, my name is Damon House. I have the joy of working with this woman every single day to hear this brilliance and much, much more. But yes, as she's talking about it, when we talk about the efficacy of how drugs are developed, when you go to a store and you say, I'd like Tylenol, or I'd like a prescription from your CVS, your doctor has written you a prescription that's tested for the everyone, not you as the only one. And so one of the things that we want to do is we want to definitely take a look and peel that back to understand what those differences look like. Were those medicines, those drugs, were those treatments tested on people like you? Were they tested in your demographic, your age range, your gender range? Oftentimes, women don't get as much love in the clinical trials as men do. We can talk about things like BMI and the stigmas that are associated with models that have been developed around Eurocentric males. But that has followed us down into some of the processes and procedures in healthcare, electronic health records, prescriptions, treatment plans, even things that they do in critical emergency situations. And so we want to have this conversation to talk about the disparities in marginalized communities, unserved, underrepresented communities that don't actively participate in the healthcare system. And when we don't participate, it's harder for the system to support us because we're not part of those clinical trials. Yes, soapbox. I have many too. So let's go ahead and dive in. And I'm sure Dr. Tania and I might pull out one or two, might get up on it, and we might give our own sermon today.
Well, this is important. We've got to have these kind of discussions because they're not readily had, and we need to inform the public. This is why we have an open mic, an open forum. Now, you both are part of what we know as GLRF, which is the Gwen Lily Research Foundation, which you started with Frenetic, and then Damon, you're the chief growth officer there. But you both are going to be at the upcoming conference for the ACRP. Now, that's the Association of Clinical Research Professionals. Tell us about, first of all, why you started this organization and what is your intent at the ACRP?
I'll go ahead and take that one. So I started Gwen Lily Research Foundation, which is named after my mother and her favorite flower. I started that organization as a nonprofit to really focus where our for-profit could not. So Gwen Lily Research Foundation is the nonprofit philanthropic arm of Frenetic. And it goes deeper into the community to provide that education and that outreach, really focused on the nuts and the bolts. When we say translating research into care, that's actually going out into the community and talking about research, making it a little less scary, bringing that information and having conversations that you may not be having with your physician in a very practical way. So whereas Frenetic is focused on the science, the genetics and the genomics, and really getting deep into the research and provider side of it, Gwen Lily Research Foundation is taking that, breaking it down into actionable chunks. We're not just providing information. The goal is to give action around that. Okay, so now you know this. What are we going to do about it? What can you do in your community? What can you do in your family? What can you do as an individual, right? The Association of Clinical Research Professionals is the premier research conference. And as the executive director and president of Gwen Lily Research Foundation, where Frenetic goes, Gwen Lily goes. And Damon is one of our board members at the Gwen Lily Research Foundation. So he's Frenetic's chief growth officer. Where he goes, Gwen Lily Research Foundation goes. And it gives us this wonderful opportunity to bring what Frenetic is doing and breaking it down into the community. Right. So this conference this year for ACRP is being held in New Orleans, which is where I was born and where I'm from. So there's a lot of personal attachment to the location, but it also gives us a very unique opportunity to leverage my friends, my family, and make them more aware. Our research, our academic institutions that we're partnered with, like Xavier and Southern there, we can give them some visibility into the research and the healthcare by actually being out in the community, which is the point. It's enough we're trying to move away from research constantly being in these circles and silos that the average person, just the average individual, isn't aware of. We're trying to make it more normal, making that accountability a normal part of your everyday. And the ACRP conference in New Orleans gives us just a unique opportunity to do that, not only because Frenetic is speaking as an organization, we have a booth, we have a presence there as an organization. I'm speaking, Damon is speaking on a larger stage with Dr. Claude Lewis Charles from Microsoft. They're sharing a tech expo stage. And we have a lot of activities planned just in and around the community. We're making sure we're having dinners that are at restaurants owned by community individuals. We're taking ourselves out and we're talking to members of the community. And even more fun, this is being held during Jazz Fest. So it gives us a big opportunity to, really be authentic in a fun way. And again, take some of the stigma, the scariness, away from research and really give people a practical understanding of what it is. Wow. Damon, I'd love to hear your perspective on it because, like I said, I don't want to talk all day, but go ahead.
Well, I Jazz Fest, I promise we won't do any singing. I promise. We when we get down there, and I have to say, Dillard and Grambling, because if I don't, then they're gonna get sore. They're gonna get upset. Right. I don't need the hate mail. We want to touch on minority serving institutions, and I'm sure we'll get into that in this conversation. But getting down there is an opportunity for us to see our peers in research. And I can almost guarantee there will be very few other organizations that look like us, that have the message, the passion, the mission, the vision, the goals like us. And she and I did a little bit of research in trying to find organizations that have labs that do the type of work that we do. And out of the 200 and almost 50 in the country, when you get a woman-owned, minority-owned, veteran-owned firm that's doing this work, that number gets really small really quickly. So this is an opportunity for us to get into these types of spaces and assert our voice and make sure that we're not belligerent, we're not angry, but we are assertive in the needs for democracy, for the democratization of clinical trials. We are assertive in the need for addressing the disparities in communities around health outcomes. And we are assertive in saying that we'd love to partner with other organizations that want to work together with us, but we need to make sure that we're all moving in the same direction.
Now, we've got some input from both of you. And I always like to jump right in, talk to the elephant in the room. And for me, the elephant in the room is around, it's in the area of health equity. But what happens when a population of people are not in the room for research? And then, like right now, we have a measles outbreak that we haven't had in 25 years. What happens when a whole group of people, when they come out with different medicines and vaccines, are not accounted for? I want to bring this over to Dr. Tania. What are the implications of that?
You have a lot of implicit bias buried deep into code. And what I mean by that is when we look at some of the tools, and most people have been a patient, you have seen a doctor at some point in your life, even just to go to school in the US, so on and so forth. These days, very rarely are you seeing doctors and nurses write things down. It's a lot of computer-based interaction, and there's a lot of automation. There's a lot of tools in place, not only to help create measurements and diagnosis and dosages of medication, but even just simple things like, for example, the pulse ox, the little thing on your finger that didn't accurately measure melanated skin. That's a very real, very recent example of what that means not being in the room. Again, we need to be realistic and remember when some of these things were created, particularly tools and resources like a pulse ox or other types of technology, it was based on male Eurocentric individuals, right? So now you fast forward a little bit and you start automating that information. The data hasn't really been improved. And that you can see that, just research any clinical trial on clinicaltrials.gov and look at their diversity breakout, which is required to be reported. So you can fact check, please do, actually. You can fact check this information. And so when you are not included in the design phase of some of this, so think of research like you're designing a drug, you're designing a treatment, you're designing a novel therapeutic. If you are not included in the room, if you're not included in that data set, then it's not for you. It's just that simple. How can you be included? And so take the emotion out of it and just look at it as ones and zeros. Your ones and zeros weren't in that data set because you literally were not there. You were not represented. So now fast forward and you have things like the pulse ox is just, like I said, that's so recent, realizing that melanated people, it doesn't capture it the same way. And what are they doing? They're trying to create a new one. But they had to get to the place where we didn't know that was inaccurate, right? And think of how many other tools. Think of EGFR, the kidney measurement. Think of vaginal birth after cesarean. Black and brown people, the measurements, the mathematical calculation for Black and brown people adds more data than necessary to make it inequitable based on stigma that has long been since disproven, right? And so when you start thinking about these things and you start applying it to, again, the everyday person's healthcare, when you go to the doctor and that doctor or that nurse that is seeing you is looking on their computer, they're not personalizing that interaction to the point, well, I don't like you because of your skin color, so I'm going to do something nefarious. No, this is code, and also get over yourself. I'm going to be real honest about that. This is code, and take some accountability and think about the fact that you need to be involved in some of these conversations and some of these clinical trials and some of these question and answer sessions when your doctor says or the nurse says, do you have any questions? Ask some questions, be involved in that conversation because it turns into data. And that data needs to be captured in order for our healthcare, in order for our treatment plans to be more tailored, particularly when it becomes more and more automated, more and more artificial intelligence inserted into these. We need to be accounted for. So that is my soapbox.
That is real talk, is what I call that. I want to sing this over to Damon because, when I met Damon, he was at Microsoft. I look at him as somebody, he knows, he understands what's happening from a technological plane. And I remember meeting him at the National Association of Health Service Executives. And first thing we talked about is that, it just seems to be that what's happening in digital technology is highly skewed, just to the same point you just said. Now, here's the question I have. Where is the accountability? If you understand, you're a technologist, you're creating a product, let's say, a device, just like Dr. Tanya just talked about, who's accountable over there? Like, you know what? We really didn't test this in a certain geography, or we didn't take, really, maybe it's not for everybody, it's for certain people. I mean, who does that?
Well, everybody, unfortunately. I mean, it really is that widespread. And just as a side note, Dr. Tanya and I have published an article on the implicit bias in artificial intelligence. So when we talk about explicit bias, I don't like you because you are fill in whatever blank that is. That's your explicit bias. You're too black, you're too white, you're too loud, too old. Implicit bias is, oh, I like you, but ... And so it's softer, and it's really not as harsh and abrasive, assertive, the word I used earlier. It's not as assertive. So really, when we look at a implicit bias, okay, yeah, you're a good enough person, but because you're African American, well, then I need to add a coefficient of X or decrease a coefficient of X to whatever I put onto your chart. And so that's the start of it. Dr. Tanya said, when you want that accountability, and you want it at the start when you create these, when you design them, but then you need them later on in the testing. And in that testing, and when you do in the market, yes, you need to go to different folks in the market and test it on them, but you also need diversity in the team that's designing and doing the tests. So you can have skewed tests. We found out years after the fact that SATs were slightly skewed. Go figure. So when you say that how is it possible for these major healthcare manufacturers to design this equipment and have the bias built in? They're basing it on the systems that are already in place. So they're not necessarily going to go against the grain, because then if they get into a major hospital facility and the hospital says, well, I need my data to look this way, and they go, but we've looked at it and this is a bias-free way, and they don't mesh, they don't get the sale. So they match up with the health record, the systems, the processes, what is already in place. I'm not going to say this to allay blame, but when you look at a Cerner, when you look at an Epic, those are two organizations that basically drive the electronic health record industry in the world. So if the biases are implicit and baked into what they're doing, any organization that then tailors itself to support those electronic health records now has carried forward that bias. And so it is subtle and soft and under the covers dangerous, because everybody says, well, no, I'm sure it's okay. I'm sure somebody's checked it out. And so they don't. And when you don't do that, you allow that bias to continue to manifest itself.
Man, wow, we need to get a handle on this. What you said there is like we're continuing the same problem that we had even before we had said technologies. It's the human bias that has been, and unfortunately, we have to go back to America's roots, let's just say that, and because they were separate and unequal. And, even though you had laws in the books in the 60s, said certain attitudes still prevailed. And this is a case in point. And this had not for healthcare, but it was in law. Happened in Alabama when they were trying to where they actually implemented an AI system. And what they did, they started pulling data from all the court records over, let's say, a 30 or 40-year period of time, and started using it against court cases. Well, when a African American male came up before the court and the recommendations for sentencing or whatever it may be came out of the AI, you got to remember in Alabama in the 60s, 70s, even before, even after, highly biased toward African American males. So when it came to any kind of judgment that came out, it was harsher. And they began to look at this like, wow, this person over here got, let's just say it was 2 years for a similar crime. This person over here got 20 years. Like, why is the machine recommending that? We've got to be very careful about what we're doing. Maybe it wasn't intended that way, but there are consequences that take place. And so now I'm going to bring it back to, we just talked a little bit about health equity. Now we start getting into precision medicine. We're trying to come there. Do you feel the fabric of precision medicine could be a way to get us to a higher level of an unbiased look at these kinds of data?
Let me take this one first. So you talked about it from a legal perspective, and I'm actually very familiar with how they're doing that. Other states are trying to pursue similar guidelines. Let's go back to health. Body mass index was designed by a European scientist when he wanted to design what the ideal man is. And so he looked around him and found European men around him, not even women. And BMI was then based on his studies back then of not studying women, but only studying white men. And it then kind of came down to the point now where it is such an intrinsic part of health diagnoses today that it's just, people know what BMI is, but it never accounted for the higher amount of muscle mass that African Americans have and are still healthy, or the lower levels of muscle mass that Asian Americans may have over their Eurocentric counterparts, and their numbers are often skewed. And now that gets baked into these systems. So when you start to say, how can precision medicine uncover what this looks like? We have to start tearing away those fundamentals of our healthcare system and really identifying who are you as an individual and what does healthy look like for you as an individual, not comparing you to a standard. Because a lot of those standards were developed back in the 40s and 50s where they didn't have enough data on Hispanics, Asian Americans, African Americans, or Black Americans. And so they made assumptions.
Mm-hmm.
And those assumptions still exist today as standards. What precision medicine does is it puts those to the side and it says, okay, who are you? And takes a more comprehensive view of you as an individual, and then starts to tailor how we can treat you. Now, Dr. Tania will go into the genetics and the genomics and the pharmacogenomics and the epigenetics and the other stuff, words that it took me a really long time to learn because they're another language. But, and I want to come back to this later on, sometimes your own doctor may not know. And that's critically important too.
I want to hear from Dr. Tania.
So Damon hit the nail on the head, and I'm going to address your question. Precision medicine has an opportunity to compare you to yourself. And just inherently saying that, you can see how that might adjust the standard because now the standard is you, right? And so it's not necessarily reinventing all of that code because no hospital or healthcare system, I mean, let's just be very honest, the cost of recode at that scale is massive. And no one wants to take it on, especially in our system where providers, nurses are woefully understaffed. It's a nationwide fact. So let's not try to boil the ocean there, but precision medicine has an opportunity to narrow that focus a little bit, take into accountability. I'm going to say it, not only your genetics, but your genomics. So if you live, for example, genomics is not only your genes, but other influences like your environment, like your diet, like your lifestyle. You can, and when Damon mentioned epigenetics, that is where your particular genetic makeup is adjusted based on you, how you're eating. Your alcohol consumption is a very real one. What can be passed down over generation, so on and so forth. And that can slightly tailor really pollutant environments can adjust how those genes turn off and on, not their existence, but whether or not they're off and on. So all of that to say, when we start looking at precision medicine and we start taking in a holistic view of an individual versus some sort of best practice from the 1950s, you can see how precision medicine has an opportunity to really tailor a treatment or a care plan, not only to you as an individual, but the population that you may be a part of. And now we start getting into, like I said, not boiling the ocean, but we can actually start to have drug dosages tailored to how much you weigh. Have you ever seen a really frail person who's maybe elderly get the same dosage of a medication of someone that's like 20 years old and twice their size? Again, that's automated, it's not on purpose, but this is the kind of thing that happens. And so tailoring something just that simple so that the outcomes are more appropriate, more applicable, have a better opportunity for wellness, than some of these best practices. So we get really excited about precision medicine at Frenetic because it has an opportunity to change the game. And as people start demanding care at home, because you can these days, people don't want to go to the doctor just for something simple if they can avoid it. I am being a little elitist when I say that because there's an entire separate section of the population where that is the only option that they have due to infrastructure issues where they live, so on and so forth. So think bandwidth. However, take that out of the picture and you start thinking about the capability of being treated at home. It's the possibilities are endless. It's a green playing field, Grant. It's a green playing field.
This is
really
important information. You both have given great information and great information to the audience about the why and the what. We still want more information about Frenetic. What is it that you are doing? How are you making a difference in this incredible world that we have of healthcare and healthcare delivery and research? Talk to us more about that.
I'll let you start and then
Okay. Okay. I sometimes say Damon is my interpreter. So I don't say that sometimes. I actually say that quite a bit. So you've heard me say, Frenetic is really applying precision medicine to research in healthcare, but how we do that is intentional. So if you are familiar with this particular industry, you'll recognize some of our capabilities, like having clinical genomics, a toxicology lab, clinical research, the ability to conduct clinical research, the ability to have data, high performance computing with that research data. What that is often done in academia. So think Johns Hopkins, Rutgers, Columbia. What we do is largely contained in academia, and we are bringing that out of that particular silo. There's nothing wrong with that. But again, our mission is to take these capabilities and bring them to all people, right? And remove some of those silos. So that's our how. And we had to look at where is the gap? I've heard you say in the past, Grant, we need to own it. We got to own it. And so how do we own the data? Well, the data in this life cycle starts with the sample collection, to be perfectly frank. So that's a blood, tissue, saliva, urine, right? That is a sample collection. We need to own that process, import that data into our software, into our data lake, right? Which is called iConcordia. That's our software solution. And we control that, and then being able to do something with that sample so we can sequence it. We have our own lab. We sequence that data to the depth and the capacity of the request. Everybody doesn't need to do a whole genome sequence, right? Sometimes you're just trying to find a biomarker, or you're just trying to find if you're predisposition to a particular condition, right? So all testing is not the same, but the point is we have the capability to do that. And then again, take that information, import it into your medical record, give you that detailed report that goes beyond a yes, no type of report, really get down and explain what those test results mean. And then on the research side, being able to talk with our sponsors. So a sponsor is any third party that's paying for research. So think about the FDA, think about Pfizer, all of these other organizations, those are sponsors. So the sponsor, they have their own goals. And when they come to a company like Frenetic, they're looking for us to give them diverse data sets. How can we go out to our patients? How can we make whatever they are trying to produce? So think a new drug, new therapeutic, new something novel, right? We want to actually be able to communicate that to those physicians, to communicate that to those patients. And again, take it out of the suburbs, take it out of academic communities. That's Frenetic. And I know I'm giving like a 10,000 foot overview, and Damon hasn't given me the stop talking sign.
We need that 10,000 for we get 2 grand, but I think we get the general idea for sure. So Damon, give us your piece.
So as a growth officer for Frenetic, it's my job to figure out how to translate that genius into market readiness. And so the way that I try and envision it and approach it is, how can I bring that set of capabilities to hospitals, private practices, universities, institutions, and others to show them how these capabilities can support them in what they do? So if you think about a typical hospital, they may be using, say, genetic and genomic testing, but they may not. The penetration is really only about 60%. When we get to FQHCs, it drops down to 50% for genetic, but genomic drops down to about 30%. So they don't have these tools in their tool belt to help the patient who walks in the door to understand what may be wrong. The good thing about genetics and genomics is it can help to identify what you may have a strong predisposition for. So if you've got diabetes, you got it, and the test is going to say it, and okay, that's fine. But now what about your son, your daughter, your niece, your nephew, your sister, your brother? They can get tested. Cancer, same thing. They can get tested, and they can identify if they have a predisposition for that chronic illness. Well, if we're not using that as a tool in the tool belt, we're waiting for people to get sick.
Yes.
And when they get sick, we diagnose them, we treat them, and the costs are higher. But if we can proactively manage that wellness, we now have the opportunity to say, hold up. If you eat better, exercise more, do X, Y, and Z, you can kind of put that off for maybe another 5-10 years, or maybe indefinitely. That begins to save an FQHC about $5,000 a year per patient.
Yes.
And so we want to increase the opportunities for that engagement. We also want to go to universities. And we are looking at the opportunity of going to a university and building a lab in partnership with them so that they can do the research. And where we can own and operate it, but they can get the benefits of having that laboratory right there as they go for higher research status, et cetera. A nonprofit who's doing the work in the community may not necessarily understand how genetics and genomics really can change a person's outlook when you factor in, say, the social determinants of health. So now we can educate them on how they can go to their churches, their synagogues, their mosques in their community and tell people what is available. So when they go to the doctor and the doctor goes, they say, "Well, I don't feel good," and the doctor goes, "Well, now you look, everything looks fine. I'd like to get a test." And they have that right, and it's covered by insurance.
Yes.
Those are the kinds of conversations where we come in. We want to have those conversations. We want to foster them. We want to support them.
That's a lot to unpack. Meaning, I love everything both of you just said. Like, yeah, we need to do this yesterday. Why aren't we doing this? I even remember what you were talking about. Federally qualified health centers. Most of those are people that are being treated are people of color, Black and brown people. So, wow, only 30%, 70%. That's a huge amount of people that aren't being treated in that fashion. Lots of room for expansion in that area. I remember, and this is back in the 70s, I'll date myself, that me and my brother got tested just for the sickle cell trait. It's a thing,
Yes.
right? You got tested, like, oh, do you have the sickle cell trait or not? Then you kind of knew, like, all right, you might have the trait, but if you get to with someone else with trait, you could, your child could potentially get sickle cell. So it was there, right? Right, this predisposition, what you guys are talking about. I love that. So why weren't we doing that? Especially when, and I know this for the Black community, our consumption of salt is too high. Our consumption of sugar is too high. Our obesity rate is too high. There are certain things that we're doing that we probably could change. And if we have more awareness, I'm going to speak to the other elephant in the room when we talk about ownership, right? We got to take ownership as a people for our health, our preventative health, health and wellness. Is that what your nonprofit arm is doing? Help me understand more clearly.
So Gwen Lily Research Foundation, by the way, it's volunteer run and led, right? So that alone says we are really focused on getting the word out. So when it comes to what you just said, people not being aware, that's where Gwen Lily Research Foundation comes in, not only for working with other community-based organizations, such as churches or other community-based groups. Think about, we were just contacted, this is a really recent anecdote. We were just contacted by an organization that is going through pre-clinical. They're just testing their theory on a particular solution. And they are leading with the fact they want to make sure their solution works in underrepresented communities. So they called us to see what was the best way to go about that and how could we assist them in getting in those rooms, because they were self-aware enough to say, we wouldn't be welcome because they're Caucasian. And I appreciate their candor. And there was no political correctness or beating around the bush. They want to make sure that what they are creating, it's a new solution. They're looking for FDA approval, looking for, the whole thing. This is brand new, not on the market, not available. And they are leading with, how can we get this into everyone's hands? How can we make sure that this works for everybody? And also, we know that we don't know how to penetrate those spaces. Can you help? That is a perfect example of what our nonprofit arm does, right? Because Frenetic is going to be focused on, well, we can help you with your clinical trial, right? But Gwen Lily Research Foundation is going to be focused on, have you tested this on different communities like deaf and hard of hearing? Have you tested this on communities that are maybe suffering from rheumatoid arthritis? Do they have the dexterity to use your solution, right? And just really thinking outside of the box. And then we start getting into, think about what I just said, deaf and hard of hearing, rheumatoid arthritis, especially early onset arthritis. Add into that equation melanation. Are you Black and brown plus some of these other conditions? So now you're adding in even more barriers and sometimes even more inequitable access to that care. So that let them know, are you thinking about how this is going to be insured? This has to be covered by CMS. This can't be only private pay or for people that can afford out of pocket, right? And so you start unpacking these conversations in a way that our nonprofit can do that our for-profit can, just naturally. Let me know if that answered your question.
No, it certainly does. Damon, you got any addition?
Really, not really. When we look at how this breaks down, she brings up a fantastic point, saying these organizations can come to us, and we welcome them. We want them to. I think one of the big challenges that we have in our community is we circled the wagons. We had some things go on historically. And everybody points to Tuskegee and they go, "Wow, that was it." No, there's been a whole lot more that's gone on, and not just the African American community, also the Hispanic, the Latinx community, the indigenous populations. Circle the wagons. Say, okay, no, we don't trust you as an organization. We don't trust that you'll use our data correctly. We don't trust that you have our best intentions at heart. And as both organizations, we want you to come to us. We want to have that conversation. We want you to believe in our community enough to take that time and that consideration, and we want to help. And that's part of the reason why when we look at universities, we want to work with universities to develop the next generation of researchers, of clinicians, of community outreach experts, of people who care and give a toot about healthcare and health outcomes.
Yes.
We want people, invite people, beg people to come and speak with us so that you can learn some of the statistics that we've pulled together around the disparities in gender, in persons who are differently abled. It's a fascinating statistics show. We almost expect that in the inner cities, the inner cities, there are going to be health disparities. We know that, but the numbers are very eerily similar to the same disparities in rural areas. And we know that the populations are very different. So come to us and allow us to work together with you. We are not just trying to save minorities. We want to save marginalized communities.
Yes.
And sadly, that's also women.
Yes.
That's veterans. Those are the people who live next door to us, who live in our house, who are our sons and daughters. Come to us and have these conversations. Ask these questions. We're happy to answer them.
Yes.
I'm glad you brought all this up. We're going to wrap up. This has been wonderful. But before I do, my thing with the healthcare system is I've learned a lot of different things over my time, and I've heard a lot of different voices, and I hear this historical context. And one thing that I have come to, especially during the COVID time period, when it was starting to come out, and they were saying certain things that you're saying, like, there's just a disproportionate amount of people being affected by certain things that aren't with others. But then we have this huge population that is not being involved, right? But they're not doing the trials. They're not doing this and doing that. And then you go back to why. And the why always comes down to, well, you treated these people poorly. Let's just call it, when you treat this population poorly. And your answer to that was not a very good apology. I was very honest. I said, did you ever apologize to just specifically Black people? Hey, you know what? I'm sorry that I experimented on you without your will and caused great pain. I'm sorry. I'm sorry that I caused great pain in cervical cancer when I, illegitimately was taking your cells from your body without your knowledge. I apologize that the Mayo Clinic that was founded in Minnesota was founded on 38 Native Americans that were hanged and then their bodies exhumed without the tribal knowledge. I'm sorry. I did not hear that, or I didn't hear it loud enough to where it made a difference in those populations, because it's not so much you said you were sorry, but did you take any action behind it? What did you do? Or you just left it the way it is. And then if you leave it the way it is, you're going to keep getting the same result. So I applaud what you're both are doing. Before I let you go, you've got to tell us how to donate, because you said it, before. One is a for-profit, one is a nonprofit. How do we donate, to your organization?
You can donate to Gwen Lily Research Foundation. It's a tax-deductible donation because it is a 501c3 or organization. So your donations are all tax-deductible. We have a couple tiers for corporate donations, particularly corporate donations for ACRP. We can provide a link to that. Our donation page is on our website, which is gwenlily.org, Lily with one L. And Grant, you'll be able to put this in text. Okay. Then we have individual donations as well. We'll have a link to that. And then just general corporate sponsorships, because again, we do want to work with organizations that have a commitment to moving this forward. And there will be a link to that. So that's how you would donate.
Thank you.
And I'd also like to add that as we think about Frenetic, it's not a nonprofit. So donating to us we'd love to work with you. We'd love to be the organization to provide your testing for you, be it basic clinical diagnostics or next generation sequencing. We're developing mobile laboratories where we can partner with you, if you're a provider, if you're a university, to go out into your community and provide these tests on site in the community. So you don't have to get people to come in. We'll go to them and we'll do it right there. And in under an hour, we can tell you, oh, okay, hey, wait a minute. Let's have some conversations. Let's talk about some things. So that's how you can work together with Frenetic as well.
Yes.
Awesome. This has been a fantastic episode. I want to encourage both of yours entire audience to tune in to all the episodes of Follow the Brand at 5-Star BDM. That is the number 5. That star, that's B for brand, D for development, M for masters.com. Before I let you leave, you got to tell us, I know you said it was during the Jazz Fest, but what is the exact date for the ACRP?
April 24th through 27th, 2025 in New Orleans. The conference will be held at the Hyatt Regency New Orleans, and we will be spot and center. We cannot wait for this.
Les le bon temps roué.
All right. I love it. Thank you again for being on the show. Take care, and we will see you soon, hopefully sooner than you think, in New Orleans.
Yes.